Hi, everyone, and welcome. Happy National Social Work Month. My name's Sally Guy. I'm the Director of Policy here at the Canadian Association of Social Workers, and I'm very happy to be moderating this webinar, Triggers of Moral Distress During the COVID-19 Pandemic, which is just part one in a two-part series with Dr. Sophia Fantus, who I will be introducing in just a second. But before I go on, I do need to acknowledge that our national office at CSW is located on the unceded territory of the Algonquin people, which is the land now called Ottawa, and that we are very lucky to be here. So this is the first English language webinar during National Social Work Month, and we are kicking it off with a bang. There has been huge interest in this event, which is great. We're thrilled by that, but I think it also signals how incredibly difficult things have been for social workers throughout the pandemic. On to the housekeeping. So all the widgets on your screen, these boxes like the one with my video in it, they can all be resized and moved around. So you can play around with that and get your screen how you like it. The icons at the bottom of your screen are all the other widgets. So you can hover your mouse over those to see which one's which. And that's where you will find the PowerPoint slides for today, some links to other articles on our website, all of that in the resources widget. The certificate of attendance, that will be sent to your email automatically a few hours after the end of the presentation. And of course, this presentation will be recorded, and you can get that on demand anytime beginning tomorrow on our website. So the presentation is going to be about 45 minutes, maybe a little longer, with a question and answer period at the end. Quickly, on the topic of questions, anyone that asks a question in the Q&A widget, because there's also going to be some engagement in the chat, which I see lots of you are already telling us where you're tuning in from, which is awesome. But if you ask a question in the Q&A widget, you will be automatically entered into a draw to win one of our masks. They're really nice, actually. They're black, and they say social work is essential on the side. They're very sleek, and we will mail them to you. So if you are selected, we will respond to your question in the widget and give you some information on how to claim your mask. We just thought it was a nice way to say thanks for being here with us during your very, very busy days. Okay, so with that, I can finally introduce Dr. Fantus. Dr. Fantus is an assistant professor in the School of Social Work at the University of Texas at Arlington. She did her PhD in social work and bioethics from the University of Toronto, in conjunction with the Joint Center for Bioethics. After her doctoral work, she completed a clinical ethics fellowship at Baylor College of Medicine. She is a certified healthcare ethics consultant and studies experiences of moral distress among indirect healthcare providers, including social workers. Her most recent project, which I think she'll talk about today a bit, was a 3-stage pilot examining encounters of moral distress before and then during the pandemic. And her ultimate objective is to develop evidence-informed strategies to help with moral distress and to enhance social workers' well-being and mental health. So you can Google her. She's very Googleable, or you can read her full bio on this event's registration page to learn more about her. But with that, it is my great pleasure to pass it over to you, Dr. Fantus.
Thank you so much, Sally. I so appreciate that opening. Happy Social Work Month. It is an honor and a privilege to be here. And I was looking at the chat from the beginning of seeing everybody from Canada and all over Canada. So I miss it. I was born in Montreal, grew up in Toronto. So it's so nice to just see everybody from far and wide from my home country. So welcome. We are going to get started today. I have a lot to go through and a lot to discuss, and hopefully it will be interesting and engaging. And I can't wait to also hear from all of you, your perspectives, your experiences, your life in the field, because it has been a really hard 2+ years of the COVID-19 pandemic. So to start off, I'm actually going to do a poll. So I just want to know who has worked or currently is working in healthcare. Leave it up for a few seconds. Okay. Wow. So I see about 90% work in healthcare. That's incredible, with 10% who don't. The 10% of you this is still going to be important to the work that you do, to the organizations that you work in. And I really want to make sure that anything that I talk about is purely related across healthcare and across different fields of practice as well. So this is for all of you, whether you've worked in healthcare or not. Have you thought about leaving your job, quitting, or resigning during the past 2+ years? So really since the pandemic started. So it's about 50-50, which I think actually says something. For us as social workers, we're in it because of our passion and our dedication and commitment. And when about 53% of you are thinking about leaving or quitting or resigning, that's a really big number. And so my last question is, have you heard the term moral distress prior to this presentation? So the term before you heard about this part 1 and registered. So, yeah. So about 60% of you have, 30% haven't. Some of you are unsure. Do not worry, I'm going to provide definitions. We're going to go through it. That is why part 1 is really about sort of those triggers or sources of moral distress to really point out. So by the end of this, you will have heard the term and you will know what it is. So for all of you, whether or not you have heard of the term, what is a word or 2 words that you associate with moral distress? So even if you don't know what it is or haven't heard of it before, what do you think you would associate with moral distress? And you can say things like pain, anger, uncertainty as a few options. And I just want to get a sense of where people are at. I see loss of hope, challenging, anxiety, conflict, fatigue, compassion fatigue, and challenging, frustration, existential crisis. I love that one. Anguish, dissonance. These are great and exactly what we are going to be talking about. Burnout, trauma, detachment, ethical dilemma, ethical dissonance, emotionally torn, helplessness, chronic unease, not knowing what to do. These are fantastic. There are so many. I love all your engagement and participation, and so many of the words that you wrote down are going to be words that are going to come up during this presentation. And so with the time that we have left, I really just want to sort of get into it. So what do I mean when I use the term moral distress? What are we going to be talking about today? So moral distress is really a response and reaction to a resolved ethical dilemma. It's where there's an ethical dilemma and the resolution, the decided course of action is not something that you think should be ethically reasonable. So the correct action, what you think is correct, what you think is ethically feasible, can't be executed due to institutional constraints. And so that resolved action fails to align with your individual moral judgment of what you think should happen. So exactly like that person who wrote Ethical Dissonance, it's where your personal and professional values are against or conflict with the structural and clinical context. It's where you are put in a very precarious situation where there is value conflict. And you think that what you are asked to do or you are asked to complete is not in line with what you think should happen. And so sometimes when we have moral distress, some of those internal dialogue, those internal conversations that you're having with yourself is, I think what we're doing is wrong. I think what we're being asked to do is wrong, or what I'm asked to do. I think what's happening to this patient is wrong. I think that if this happens, we will be doing the wrong thing. So if you ever sat with that kind of internal dialogue, you might have been experiencing moral distress, because what you're saying is, you are being asked to do something, asked to complete a task that you think is wrong, that you don't think should be happening. And that's where moral distress comes in. And that's how it's different than things like burnout or compassion fatigue, because it's really centered around an ethical dilemma that is happening and has happened. And so this is just a screenshot of a page. So what I want to bring up is that during COVID-19, many people have been talking about moral distress. And so I did a quick, very scholarly Google search where I put moral distress during COVID-19. And as you can see, everything that popped up was about nurses. AACN, moral distress in nurses, coping with moral distress, nursing 2022, medicine, American nurses, hospital nurses. And I started to think, where is social work in all this? Where are the social workers? When we start talking about frontline workers and we start talking about superheroes, many of those op-eds we've seen, many of those newspaper articles show nurses, show doctors. And nurses and doctors are so important. That is not to disparage them. But I think social workers are often being left out of the conversation, whether we work in healthcare or outside of healthcare. And so what I want to do is I'm going to contextualize some of the prior scholarship on moral distress. I'm not going to get into a lot of research. I'm going to keep it very broad in terms of the results to connect to those practitioners in the field. But a lot of what's been talked about in terms of moral distress is from a nursing and medicine perspective. So there's clinical situations that may trigger moral distress, and that's like the withdrawal or continuation of life-sustaining care. Some working conditions like the inappropriate use of medical resources or pain or symptom management. Structural conditions like a lack of administrative support or feelings of powerlessness. And then moral sources or internal constraints. So when it disaligns with your professional code of ethics or your values. And so those are things that have happened, and a lot of prior work in nursing has mentioned that these are triggers of moral distress. And so some of those examples, like I said, are inappropriate use of scarce or limited resources, performing life-saving actions that only seem to prolong death, continue life support even though it doesn't help the patient or appear to help the patient, inadequate pain relief, misplaced hope to patients and families. And what you can see from a lot of this is a lot of actually direct care. And although social workers do provide direct care, this is kind of hands-on medical care. And so what I started to see from this is saying, well, if we're using this to explore moral distress, these items actually aren't relevant necessarily to social workers. This is not what social workers are experiencing. And I started to be curious as to what are social workers experiencing? What are social workers' triggers of moral distress? Because if we don't know their triggers, then we can't help to alleviate, that we can't move to that next step. And so what are the implications of moral distress, right? When I say to the next step to alleviate moral distress, why do we need to alleviate moral distress? Well, there are short-term implications, and this is again what the research has shown in nurses: physical, headaches, GI symptoms, heart palpitations, stomach aches, nausea, things like that, emotional, frustration, anger, resentment, guilt, psychological, so that's increased apathy, anxiety, depression, jadedness, sometimes panic attacks. And then occupational, not wanting to go into work the next day, taking time off, avoiding certain patients, avoiding patients that cause moral distress, wanting to work on a different floor, right? And then all those short-term implications become long-term implications. So I'm thinking things like burnout and compassion fatigue. So obviously we sometimes think about moral distress as burnout, but actually moral distress may cause burnout. Investment in quality patient care. You think, I don't want to go to work today. I'm just going to be in and out. I'm going to disassociate. I'm going to be apathetic about what happens to this patient. And then it has impacts on job satisfaction. So higher turnover rates, absenteeism, retention. And that it happens to disengagement from patients and work. So if moral distress isn't talked about and then isn't alleviated, these long-term implications have actual individual consequences on us as social workers, but then also have higher level consequences on our organizations, on our health systems, on leadership. And so if moral distress isn't talked about, what winds up happening is what's called moral residue or moral crescendo. So when there's unresolved moral distress, that moral distress moves to the next patient and the next patient, or your next client. And what happens is that moral distress builds over time, and the reactions intensify and escalate and become deeper and harder to disentangle and harder to overcome. Meaning it goes back to that one of the first questions I asked was if you've considered leaving your job, if you've considered quitting or resigning or potentially leaving healthcare altogether. And oftentimes when moral distress isn't talked about, isn't resolved, it's really indicative of deeper systemic problems that are happening over the time and within and across your organization. And so the COVID-19 pandemic has obviously exacerbated all of this. Moral distress has been happening in health systems for years, but COVID-19 has really drawn it out to the forefront. We have heightened experiences of moral distress. We see news stories on frontline physicians and nurses. We hear narratives of limited PPE, COVID-19 exposure, restricted resource allocation, ventilators, lack of community-based resources and supports. And these have lasting consequences on provider retention, impacts on patient care and patient experiences, and this shared trauma and collective moral distress that we've experienced. It's funny because I was talking to a nurse recently, and she said to me, now that COVID-19 is over, or after COVID-19, and I thought to myself, is COVID-19 over? And I think that we tend to have this view of, well, if we see rates going down, right, mask mandates being canceled, things going back to relative normality or normalcy, we tend to think that we've moved past it. But what we tend to not understand or think about is this prolonged trauma that we've all experienced together and those lasting implications that will continue for years post-COVID until the next pandemic hits. And so even though we think maybe this is post-COVID or after COVID, I think that we really need to consider our continued care, whether it's self-care or whether it's provider care in the long term, right? Because these are going to happen for years. We are not just coming out of this collective trauma. If this is unresolved, this is going to have implications on our work for years to come. So what was my project? My project was to identify triggers or sources of moral distress for healthcare social workers. My project happened across the state of Texas, but I'm really hopeful that obviously these will be experiences that people can relate to across geographical locations, because as I said, we've all experienced COVID-19 and we're all kind of have been in this together. So mine, as Sally had mentioned from my work, was a 3-stage research project. So in early 2019, I did a pilot project at one institution where I just interviewed about 30 participants at one healthcare system about their experiences of moral distress. In fall 2020, as I was coding my data and trying to write it up, the pandemic hit in early 2020, and I decided to conduct interviews across the state of Texas. Now, I conducted interviews with social workers and chaplains, but today I'm going to be obviously focusing on social workers. And then in summer 2021, when the Delta variant hit Texas and we had increased number of cases, ICUs being filled, I did additional recruitment. So I interviewed a total of close to 100 social workers for this project over the course of all 3 stages. I'm not going to get into my methodology or anything like that. So if you have methodological questions or research specific questions, I'm happy to answer those. But I really want to get into the results and how this has impacted practice, right? And then things to look at moving forward. So what did they say pre-COVID-19, right? What were their sources of moral distress? When I say pre-COVID-19, I say these were themes that resulted across all 3 stages, but were really prevalent in my pilot work. After I discuss these sources, I'm going to go into specific themes that really came up during the COVID-19 pandemic that I didn't necessarily see before. So these situations are not just in the pilot work and never appeared after. They did appear after, but it also was not kind of connected to or indicative of the pandemic. So in terms of clinical considerations, social workers talked about that incongruence between the best choice for the patient and a physician's orders. So obviously, us as social workers, we don't work in a silo, we don't work in a vacuum, we work with individuals. And oftentimes we are at sort of the beck and call, if you will, of physicians' orders and consults. And so sometimes social workers talked about being asked to do something by a physician that was not in line with what the patient wanted. And that was a source of their moral distress because they felt pulled in two different directions. Do I do what the physician wants me to do, or do I do what the patient wants? Delayed or rushed end-of-life conversations. So these were where they would be consulted very last minute to put somebody on hospice because that patient was dying, and not to be called before, because oftentimes the physician thought that they could handle those end-of-life conversations, that they were responsible for doing that. And then a social worker would be consulted in last minute to have a very rushed conversation around end-of-life treatment decisions. What that resulted in was limited code status dialogue that really failed to align with the patient's values and wishes, because by the time they were called in, the patient had lost some sense of autonomy, and there wasn't a lot of time to have a really in-depth exploratory conversation about the patient's values and wishes at end of life. And then patient autonomy, where patients' autonomous self-determination failed to be in line with what the social worker really wanted for that patient, what they thought the patient should get or should move forward with. And so I'm going to use quotes a lot because, one, I do qualitative research and love qualitative research, and I think it is really important to highlight voices, but I also want to normalize experiences that you may relate to that you may see yourself in these stories, and to know that you are not alone in this, that other people have these shared experiences. So this individual says, what I've noticed is that we wait until the very last second to bring up hospice. It's documented multiple times if I've met with the family that hospice should have been introduced earlier. Why do we wait until the last minute to bring it up? And another person wrote, she was just diagnosed with breast cancer, stage 4, METS, and the issue is she's homeless. She has resources, but she chooses not to use her social security check to cover housing. She just kind of bounces between her family's house and living on the streets. I don't think a lot of the professions understand that we can't force a patient to do anything. I've given her all of these resources, different avenues of trying to find permanent housing, but she wants free housing. So that goes back to patient autonomy, right? Where that social worker wants to do something more, but she has to understand that this patient is wanting to be homeless and she can't force her to do anything. Working conditions. So these were intermediary obligations. So again, it goes back to that clinical, where it's that incongruence between the physician's orders and patient's sense of self. But those working conditions are those intermediary obligations where you kind of still feel like you need to respect or build trustworthiness or integrity with physicians or nurses, and yet they ask you to do things that are beyond your scope of practice or are inherently not what the patient wants. And you're not sure what to do. You are being pulled in different directions, but this is based on that working condition and not necessarily a treatment plan or a clinical consideration. And then many of our social workers talked about just the overall lack of supervisory support or adequate management. I'm not sure if it's the same for some of you, but many of my social workers do not have social workers as managers. They have nurses. And that's not necessarily a bad thing, but it wasn't seen as beneficial to them because they felt like many of their managers didn't understand their day-to-day activities and weren't really with them on the ground in terms of helping them go through morally distressing scenarios or situations. And so this is a bit of a long one, so I'm going to read it, but I think it's a very important narrative to share. So they say, we don't want hospice for my dad. That's not what he would want. So I documented very clearly that's not what the family wants. The doctor put another order in for me to transition to hospice, and I had to call him and let him know that this is not what the family wants for the patient. This is not what his wishes were that he laid out for the family to carry out. And he became very, very irate and upset with me, and he took it all the way up to my management team. The doctors wanted him out, wanted him transitioned to hospice, and move him to the inpatient unit, because if he were to pass away on his watch, it would go against his mortality. That was a battle I got into. I was really upset with the doctor because he was telling me to do one thing that the family didn't want. I also have to advocate for the family. Do I honor what they're asking me to do, or do I continue to press and pursue and say, this is what the doctor is wanting us to do? I think he saw my role as make the referral to hospice and get him out of here. These are two other quotations based on management support. So it's my personal experience and the outcome. So when they talk about outcome, they're talking about what their managers tend to help them with. And the outcome has not been supportive. The outcome has been punitive. And for others, I can think of several other social workers who've shared with me things they've shared that were inappropriate, that management didn't do anything about. And in talking about this, another one said, I don't have someone who's side by side with me, who actually gets where I'm coming from and actually sees how hard this is. And one of the important things that I want to bring up about this is this enhances stigma around experiences of moral distress, but also shame, moral anguish, and silence. And when we deal with moral distress with silence or shame or disengagement or not wanting to share because you don't feel you have that support, we go back to that moral residue or moral crescendo where it's going to keep building and building and building because you don't have anyone to talk to about it. You don't have any solution-focused approaches. You don't know how to manage it or deal with it in your workplace. And it is going to keep happening. Then I'm going to talk about structural conditions. So these are a little bit not Canadian, but it might be a little Canadian specific, or we can talk about ways in which that appears in Canada. But we faced a lot of insurance barriers. Obviously, we live in the States, and this is just one of the things that we have to deal with on a day-to-day basis, and internal hospital constraints. So like that large narrative I read who said it counts against their mortality, internal hospital constraints, which I know happens in Canada as well, are length of stay, number of beds, mortality rates, all those things that you're hearing and those messages that you're getting and receiving from the hospital that pushes discharge planning, right? That pushes getting patients out faster and quicker without a care of, am I providing the best course of action? Am I providing the best care? But oftentimes you feel tied in terms of making that decision because there's no other option. And so with insurance barriers, there was this one that I felt was really, really powerful. So my primary unit is on the stroke floor. There are all walks of lives and socioeconomic backgrounds that patients come in with and come from. So it's especially distressing when you have patients who don't have insurance and have had this major life-changing thing happen. We had a relatively young patient. He was 41. He had a stroke, a major stroke. He didn't have insurance, so there was nowhere we could place him to get additional physical therapy. If you have insurance, you can go to rehab, you can go get home health. We wound up placing him in a nursing home at 41, which was really distressing. It was personally seeing someone so young to have to place him in a nursing home that young because he needed the extra help and he couldn't get it only because he didn't have access to the resources. And I know this is related to insurance, but when I think about Canada, I also think about geography and rural communities. And I can imagine that many of you may have experienced very similar community-based resource allocation or limited resources in terms of having no other option based on where that person lives or based on being in a rural community. Or based on being very far away from a main center that provides that type of care or that level of care. So when we talk about that idea where social workers are responsible for a continuum of care and to ensure that that patient, when they leave the hospital, are being cared for, that same thing I can imagine happens in Canada, perhaps on a different level. And then I'm going to go into the sources of moral distress. And those are those moral sources. There's internal sources. And these are power differentials. So we all know that social workers are at the bottom rung, right, of the ladder. Many of the mission and the aims and the sense of health systems surround nurses and physicians and surgeons. And social workers often feel a lot of powerlessness in terms of having a place on leadership, in terms of having a voice, in terms of being heard. And that really tended to happen with many of my social worker interviewees. Many of them talked about that lack of even familiarity or being asked to work beyond their scope of practice, or alternatively, not really seeing their level of skills. Many of my social workers talked about the idea that physicians just think they're the bus pass girl, right? Just think that they're able to deal with insurance and nothing else, that they don't do therapeutic support, that we don't have masters and postgraduate education levels, that they don't really understand the skill or the training that is available to us. and as well as organizational value. So that happens at an individual level. But again, many of my participants spoke that the organization or the health system as a whole fuels that and facilitates surgeons and physicians and nurses to look down on social workers, because many social workers don't have a place at the table, don't have a voice in terms of policy decisions or practice decisions. And so when they put so much financial investment and emotional investment into those top leaders and health leaders, they tend to say it's okay to put social workers at the bottom. And so there's that stage two that's happening with these moral sources, where social workers don't feel like they want to say anything because they fear retribution, they fear stigmatization, they fear being fired or being moved. I had a social worker who didn't want to say anything because she loved the department that she was working in. She loved being on the ICU, and she didn't want to say anything because she feared that they would move her to a different unit, and that they wouldn't look up to her anymore or think that she couldn't handle it because she had experiences of moral distress. And so here's a couple of quotes that people had said. So, physicians and surgeons only think that we're there to talk to the patient about their care plan. I don't think that they fully understand what we do and what type of support we can provide to them. A lot of my training has to do with mental health, and so I feel like I'm not utilizing my full skill set, what I was trained to do. We get talked to like we're stupid. People treat us like we're at the low end of the totem pole. I don't think they appreciate how much education we have, the focus of our education, and our capabilities. And the last one is they don't understand that I can't magically make things change. You're putting me in a very precarious situation because you're telling me to figure it out. And I'm telling you there's nothing I can do. I feel helpless for the patient's sake. I feel helpless as a professional. Everyone is looking at me to fix it, and I don't have a way to do that. And so obviously you can see how demoralizing that could be. And when we go back to those short-term and long-term implications, physical, emotional, psychological, occupational, obviously thinking about that can have long-term ramifications. And so now I want to switch gears a little bit to kind of the focus of this conversation and the focus of obviously the title of this presentation, and look at a little bit about what people have talked about during the COVID-19 pandemic. So this was in fall 2020 and then summer 2021. And one of the reasons I waited until fall 2021 is that when the pandemic hit, it was really scary, and I didn't feel like it was ethically appropriate to ask folks about what was going on so soon after it begun, and when ICUs were being filled and people didn't really know what was going on, and there was a lot of uncertainty and fear, and there still is now. But that's one of the reasons I waited until fall and waited a few months for the pandemic to kind of hit and for us to have actual meaningful conversations around this. So one of the big things that I saw regarding clinical considerations is this patient autonomy versus community safety. If we think back to the moral sources pre-pandemic, they talked about patient autonomy, right? So they said, well, she's choosing to be homeless, and I don't agree with that. That's not what I would hope that I could provide her with more, but this is the patient's autonomous choice. But now with the COVID-19 pandemic, social workers have to wrestle with patient autonomy and community safety. Because if a patient tests positive for COVID and wants to go back into the community, there is concern there of, what do I do? Do I tell a homeless shelter? Do I tell the community? Who am I responsible for? I had one social worker, and this isn't in the quotations, and I want to bring up this story because I had one social worker really wrestle with that, because a patient was ready to be discharged, and that patient tested positive for COVID, but they were ready to be discharged. They didn't need to be in the hospital anymore. The only way the patient could get home was through a taxi. And my social worker started to talk about and question, do I have to tell the taxi cab driver? Do I have to tell the Uber that this person has COVID? Well, that violates HIPAA. But what do I owe to the community? How do I ensure that there's community safety? Similar to before, but now exacerbated, are end-of-life values and wishes. When people are coming in on ventilators or really, really sick from COVID-19, There wasn't enough time to have these conversations. And some of the patients were really, really young. So there were no prior conversations or dialogue regarding end-of-life values and wishes with that patient. And then the big one was caring for patients, for families, and for medical teams. One of the things that I'm going to keep bringing up and that I'm going to bring up in part 2 is that social workers have been asked to care, not just for patients and families and their trauma and their grief, but the grief of medical teams. So I'm not sure if any of you have been in this situation, but when experiences of moral distress happen on units and there's a debrief, what I've seen is that often social workers are asked to facilitate that debrief or go in and make sure everybody's okay. What winds up happening is that social workers are then left out of the conversation, and they are not seen as members of the interdisciplinary care team that also are experiencing moral distress, that also need a way to debrief, that also need to do all that. And so during the COVID-19 pandemic, this was escalated where social workers were asked to care for everybody and care for the medical team, and how much that must have cost these individuals. So a quote that I have is, we get a lot of people from halfway houses and a lot of homeless people, and some of them have been testing positive for COVID and they don't want to go to isolation, and you can't force them. I sat on the floor in full garb one day for 5 hours, having, because I had to stand 6 feet away, having like a shouting motivational interview style conversation with this client, just really going over pros and cons, really trying to help him understand public health, really trying to help him understand why it's not appropriate for you to go back to your halfway house that has 20 people in it when you have COVID. And he did agree to finally go to isolation. And everybody was like, why did you spend that much time there doing that? And I was like, because it's important. Working considerations. So obviously many of the social workers that I talked to experienced increased caseloads, limited PPE, and interprofessional obligations. So that back and forth with asking social workers to do even more beyond the scope of practice, to take over from other people who weren't there because of staff shortages. There was also a real lack of transparent communication regarding administrative policy changes. So I'm sure many of you remember that with visitation policies, they would change almost every single day. And there was a lack of transparency where sometimes social workers were put in precarious situations where either they would say the wrong policy, or they would be the ones having to tell someone who was dying that their family couldn't come visit them, that their family couldn't come to see them. And so there was that they were left out of these conversations and yet put in positions where they'd have to tell families these policy decisions. And so that felt really unethical and put in a sense of real value conflict because they didn't agree with these visitation restrictions. Because as social workers, we understand the importance of family, right? We understand the importance of closeness and attachment and touch and all those type of things that are very important, especially at end of life. I voiced feeling burnt out to my boss last week. We were already short-staffed before COVID hit, and we're even more so now. We've definitely had a lot of turnover. A lot of people have quit on us. I mean, our role is definitely a very thankless job. I feel like social workers in hospitals either get the rap of, we are going to call CPS and get your kids taken away, or we're going to give you free stuff. You know, there's always something wrong when you get called, but I think being short-staffed has really affected us. It's just a lot of extra responsibilities and new responsibilities are being put on us. Structural considerations. So this goes back to those visitation policies, but actually trying to follow HIPAA guidelines and CDC guidelines. So when the CDC seems to change in terms of mask mandates or visitation policies or things like that, as well as HIPAA guidelines regarding patient confidentiality and anonymity, those really impacted their day-to-day job responsibilities. And then macro level social justice considerations. So this is really kind of maybe US based and US focused, but many talked about the shifts and changes that so dramatically appeared in our healthcare system, right? In our healthcare work. We know that the US is very problematic. I know Canada has issues as well, but obviously with insurance and that folks are not being able to afford being put in hospitals, right? Being put on ventilators. So the COVID-19 pandemic, really seeing this and witnessing this on a day-to-day basis, really strongly shifted social workers' mindsets regarding those macro level social justice considerations of having to really change and shift our healthcare system as a whole, and the federal policies guiding that. So this one regards visitation policies and CDC mandates. So we weren't allowing visitors into the hospital, and having people die because of COVID-19 and not being able to have a family member there with them, that's very difficult on a social worker to say, because they'd be put as a responsible individual to tell them that, no, we need you to leave. We understand you want to be here, but you need to leave. And I did have situations where I had to, help them find the door because it wasn't appropriate for them to be there. And that seems so counterintuitive to our professional code of ethics, to our dignity and worth of persons, right? If we think about our code of ethics, as well as just respect for all individuals and respect for trustworthy relationships and relationship building. This is another one. And I think that's where some of the frustration comes from, because you just run into these maybe political or unfortunately these red tape lines in the field of healthcare. And it's frustrating because maybe if we had Medicare for all, or if we had more regard for vulnerable people, even families, especially in light of COVID-19, where every other person I felt lost their job or lost their housing, can't pay for medication anymore. I think those are cases that lead to greater moral distress. So this wasn't necessarily one patient or one case, but it was putting COVID-19 in a limelight that showed the healthcare system and the gaps and pits of the healthcare system as a whole. And then moral sources. So as we're getting to the end, those internalized sources of moral distress. So personal and professional value conflict amid fluctuating job responsibilities. So many people had value conflict around being asked to do things that are beyond their scope of practice, that are beyond their skill set even, because of certain things. So feeling that value conflict of, should I actually be doing this? Should I be saying yes to this new job responsibility? Because I'm being pulled in a lot of different directions. A new thing that came up was personal safety and exposing others to COVID-19. Folks said that they didn't see people for months because they worked in a hospital and they didn't want to see friends. They didn't want to see families. They didn't want to see loved ones. People were caring for elderly parents or small children and were worried every day going home about their personal safety and exposing others to COVID-19. And so this was really that internal value conflict of, I have to do this job, I have to care for other people, but I'm putting my family at risk, or I'm putting my loved ones at risk. Devaluing social work competencies. So even during the COVID-19 pandemic, social workers still felt like their competencies and skill set were devalued, because what did we see in op-eds? What did we see from health systems? That it's about the physicians, it's about the nurses, it's about those hands-on medical providers. And so many people spoke about feeling as though social work was non-existent, was silenced, not only in the media, but within their health system. And then obviously conducting assessments and meetings remote. Social workers were one of the first individuals who at least I spoke to who said, well, you can do your job remote, you can do family meetings remote, you can conduct assessments remote, which really felt not in line with our professional code of ethics and the values regarding human connection, touch, face-to-face contact. Folks talked about not only that awkwardness, but the moral distress of having to tell somebody that their loved one was dying, or ask about end-of-life wishes on a Zoom call, right? And so really trying to navigate that in an ethical way. I don't like when social workers get treated like the doctor's personal assistant, like we're an extension of the doctor. I'm not. I'm my own licensed clinician. I have my own mind. I have my own professional ethics and values, and I'm going to stick to them and adhere to them. And so what are some of the implications that folks talked about as we wrap up? Many individuals talked about similar things that nurses and physicians talked about. So those short-term physical implications, like getting heart palpitations, stomach aches, exhaustion, loss of sleep, emotional feelings of helplessness, anxiety, sadness. I go back to those first words that you brought up in the chat, and I see these coming to fruition here, right? I see a lot of this frustration and anger. Occupational is that fear of retribution or consequence, time away, days off work, disengagement in patient care or from your colleagues, and then that psychological, so disassociation and trauma, professional apathy, feeling numb, feeling burnt out, You start questioning your professional competencies and patient care. And you keep perseverating on, did I do the right thing? Did I do everything that I could have done for this patient? Do I need better skills or better training? Have I been trained enough for this? And you start doubting yourself and doubting your own capabilities. And so what I want to end on is something positive, right? So even through all these negative implications, all of my participants mentioned the positive consequences of moral distress. They talked about their passion and dedication for their work. They talked about the meaning and reward that they have. They talked about patient success stories and being able to even make a difference in one person's life. And through these morally distressing scenarios, they learned how to cope or strategize with ethical conflict. They learned how to empower or educate others about moral distress, but also their own skills and competencies. They became effective communicators with their teams. They advocated for change on a deeper level and on an institutional level. They gained self-confidence to speak up and conduct work. They learned how to identify those triggers or patterns, so maybe they could remove themselves from that scenario. Maybe they knew that they would have to engage in more self-care practices. And they also talked about how this encouraged and enriched their professional development. So even though we focused on those negative consequences of moral distress, what I want to say that even through every conversation I had, folks brought up positive implications. They brought up what they learned from these scenarios and tried to focus on their moral resilience. And so on that, I know this has been a heavy topic and I want time for us to engage and chat. What I want to ask is, what are you going to do today for you? And I want that to end on sort of a more positive note and to look forward to not only part 2, but to celebrate Social Work Month and to celebrate all of you who are doing wherever you work, whether it's in healthcare or outside of healthcare, the important fundamental work that you do and the lives that you are changing during this pandemic. Because I think at the end of the day, we need to remember that and to encourage your voices and to not stay silent on this and to know that you are appreciated and valued and respected. And so I want to thank you so much and just show my last slide of I open this up to questions, thoughts, reflections. Anyone is free to email me. My email is at the bottom. I am always happy to engage more. And I also want to put a shout out to my part 2, where we've talked about all the implications, but I'm going to be talking about the now what, the moral resilience. How do we move forward from this?
Oh my goodness. Okay, so first of all, thank you so much, Sophia, for this presentation. Sure. Wow, I have never seen, we do a lot of webinars, I have never seen the chat this engaged.
I saw moving and I just couldn't read it well presented.
So I'll tell you, and I'll also tell the audience, because I know that many of you had some incredible reflections and so much sort of shared experiences and also shared frustrations that we will get. I will be sending a transcript of the chat to you, Sophia, so that you can see what the comments were, and maybe that helps inform your next presentation, just so you're aware. So obviously, this was really resonating with people. This is great. We can get right into questions, which there's already a lot. So I do apologize if you did type your question in the Q&A box and I don't get to it. They started coming in very quickly once I reminded folks. Okay, I'm also going to be trying to combine 2 or 3 questions into one that were similar, because we're getting lots of sort of similar questions. So we talked a lot about interdisciplinary teams, including being managed by other professions and sort of that powerlessness. So we had 2 questions that I think are related. One of them is, how do we bridge the divide among these interdisciplinary scenarios? And then related, any tips on how to start a conversation with a non-social work manager or employer about these problems? I feel like, and then people are saying, I've tried so many times, I feel like I'm being dismissed. I would appreciate some points with that. And then my addition to the end of that, so now it's 3 questions, I'm sorry, is, and how important do you think this is as an aspect to helping with moral distress, to bridging these divides and talking to employers?
Great question. The short answer is come to part 2. The longer answer is, there are multiple ways. So one, I will say that there is a huge silo effect. Whether you work in healthcare or not, there is a lack of understanding. And I think that there's an impatience to it, almost. Like a lot of the social workers I spoke to and working as an ethicist at the hospital, I saw this a lot, where social workers would try to explain, that insurance takes a while, or figuring out a long-term care plan or figuring out discharge takes time. And so an hour would go by and the physician would come and say, well, why aren't they discharged yet? And you'd be like, this is going to take like a few days. So a lot of my participants really spoke about the ability to have some sort of in-service education. I think this really starts, and I hate to put it on physicians or nurses, but I think it really starts early on in our education, right? I'm talking about medical school, I'm talking about nursing school, and I'm talking about residency and new physicians and continuing education. Many of my social workers wanted in-service education to actually have workshops dedicated to this is what social workers do. This is why it takes so long to figure out a discharge plan. Social workers do a lot more than this. One of the social workers I spoke to worked on transplant, and they talked about, could you just get in there and figure out their insurance and support system? But I think that they're really struggling with X, Y, and Z. And the social worker was like, well, I can go in there and, talk to them about their struggles, talk to them about their anxiety and frustration or fear. And they were like, wait, you can do that? And the social worker was like, well, that's what I'm trained to do. That's what I learned in my MSW. Like, that's my whole framework. Like, I do the insurance and the case management and all that. Sure. But I'm like, learned to be, to do counseling, to interpersonal communicate with folks. And so I think that there's a way in which we need to train and educate those outside of our work. And the other is also, a part of that is also learning the language. Some of the social workers I spoke to said, I learned who I got to work with, and I learned how to effectively communicate with them. I picked up on their language. I picked up how they respond in a positive way. And I learned how to communicate with that individual or that team in a way that was helpful or beneficial to me. So it's not necessarily like I learn one language and I use that across the board. It takes time, right? And part of that is if you're moved around a lot, that's less effective. But if you're on a unit where you're going to be on that unit for a long time, it's learning how that other person communicates and trying to mimic that interpretation where they gain a sense of respect and you're able to be more honest and forthcoming with them. So those are two very brief. It doesn't always work, right? I think what I want to remind folks of is moral distress is a chronic daily condition. It is a part of what we do. What we hope to alleviate are those negative stress reactions. But I think that I'm of the mind that I think it's wrong to say we can totally ameliorate or prevent moral distress. I think it's just going to happen based on what we do. In terms of advice for talking to your manager, some of the social workers I spoke to, and I don't think that this would happen, especially during COVID-19, was to ask your manager to shadow you for a day, to ask them to really see you on the ground and see what you do. I think the disconnect that is happening is that you talk to them and they don't really understand what you are doing. So if you say, it doesn't have to be for a whole day, it could be for an hour or two, you pick your hardest hour that you usually have, whether it's that 7 a.m. that you get in there that pardon my language, but like shit is hit the fan and it's going to be bad and you want your manager to see that, ask them to shadow you. The second is advocating for yourself to get a seat at the table and to try and move up in leadership. And the third is really along with that shadowing is that to understand that your manager is also, it's like a trigger response. They are getting something from leadership, right? They are getting something from their managers. So they're getting the pressure and then they're putting the pressure on you. And that's where I come with the totem pole too, is that yes, your managers are managing you, but they are also getting pushback from somebody else. So maybe having that conversation, not necessarily making it about you, but making it about the system might help. And therefore it takes away some of that blame on the manager and reflecting about it as a whole rather than making them potentially be defensive or not understanding. But I think trying to get them to shadow you would be a really helpful bridge. I don't know if I answered all 7 questions, but I tried.
No, I think you did a great job of answering the three that I combined for you. And sorry to everybody. Of course, this is always what happens when we have an event. My internet is not cooperating. So you get to see periodically a lovely picture of me from 2014 or something like that. So hopefully that's not too distracting. But Sophia, I can hear you perfectly. Okay, there are so many good questions. This one's a bit of a different direction, but I'm also getting one very similar ones to this as well. So this one is, as social workers, we work through a non-judgmental lens. And then working in healthcare through the pandemic has created moral distress as decisions were sometimes made with no time to really appreciate the whole context. So, which ethical tools or evidence-based tools can be used in healthcare to support ethical decision making?
So that's a great question, and actually something it's a side project of mine that I'm working on now, but there are a lot of ethical decision-making tools. One, if you work at a health system, you should hopefully have an ethics consultant there who can help debrief moral distress and help you through these scenarios and these decisions. But the Joint Center for Bioethics came up with this, what's called an ideas framework. It's also been known as like the 4-box method, but what you do is you basically think about the clinical considerations or the facts of the case. You then think about the ethical principles that are involved. You then think about the different courses of action you can take. And then what you do is you decide the course of action. Now, what winds up happening with moral distress where you can is that, so you follow that, right? And then what happens when moral distress happens is you pointed out what should happen, but that can't happen because of the institutional or individual constraints that are preventing that. So it's almost like you could have that ethical decision-making toolkit, you could have all those evidence-based tools, but at the end of the day, the moral distress may still happen. But with those evidence-based tools and with that ethical decision-making, and I always think that social workers should be trained in ethical decision-making, because what happens is we're often called into family meetings when there's disagreement. We are seen as, experts in the field to try and manage and mitigate and do all that stuff and advocate for patients and families. And so if we have the tools and the knowledge to integrate ourselves into ethical deliberations, there's always a chance that we might be able to prevent or mitigate moral distress because we are engaged from the beginning. So it is called the ideas framework. It is an ethical decision-making framework to help determine what the best course of action is. There might be not time, right? Especially during the pandemic when people are coming in very, very sick and decisions have to be made very, very quickly. There might be not enough time to engage. And that is part of the moral distress too, where things happen so quickly and you're still wondering what happened to that patient. Could I have done something different? Should I have done something different? Those questions are experiences of moral distress. So that I would get involved in ethical deliberations. I would look at those frameworks. And if you do have an ethicist or even a consulting ethicist at your health system, I would definitely have time to chat with them about it, get engaged. Some health systems have ethics committees too. They don't have one consultant, but they have an entire committee. That's one way you can engage too, to understand the process a little more. Usually they're recruiting because it's voluntary and takes time. So if your health system has an ethics committee, that could be a great way also to get involved.
So that was a fantastic answer. Okay, we have time for one more question, and I'm going to do the big job of combining a lot of people's reflections and questions into this one package, which is, and I'm sorry to not really be ending on a very hopeful note, although I know you wanted to try to do that, but there's this feeling in the chat and in the Q&A about society, and I'm going to read one of the questions, and it says, during COVID, some have lost their jobs or their income has been reduced, et cetera, et cetera. Mental health should be accessible to all. Is this an example of moral distress? And then other people are commenting like, is it possible to even solve moral distress in a society that doesn't take care of us, that doesn't align with social work values? And then I will tack on the end just a really poignant comment from someone in the audience, which was, I can't magically produce housing. I wish I could, I really do, people just seem to expect social workers to find resources out of thin air. So I wonder if you could just reflect on where we're at societally and how you see that impacting fixing this.
That's a great question, and thank you for those who put those comments in. I mean, you are echoing exactly what my participants said. So even living in Canada, where we're seen as an idyllic world to those living in the States, whenever they see me, they're like, oh, Canada, your healthcare. We still, are faced with limited, scarce resources. And you are echoing exactly what my participants talked about in terms of saying, I can't magically do this. You want me to fix everything, and I can't. And oftentimes that relates to social workers being seen as anything non-medical, right? They want me to do everything that's just not medical. It doesn't matter if it's in my scope of practice or not. It doesn't matter if it exists or not. They just want me to figure it out. And so I think what you're raising is something really powerful that connects back to moral distress is chronic. I don't think that we can prevent it. I don't think that it will just go away. I think that it is part of our work culture where we have limited resources, we have limited allocation, we have limited healthcare services, we have limited community-based services, and we have more individuals who will need it. And it also connects to, your conversation around mental health and caring for us. It connects to our North America work culture, right? Where we feel guilty for taking off time. And this will connect to part 2, what I'm going to talk about, but it's the way in which we also talk about self-care. And what I want to put on is not that self-care and mindfulness and yoga is not important. It is. But what I feel like the conversation is lacking is that it puts an individual responsibility and an individual burden on recognizing moral distress and then caring for ourselves, rather than putting it in our institutions and our society to actually enable and facilitate and implement mental health. So, and I think about the stigma of mental health, right? If you broke your leg, you can call off work and be like, I broke my leg. And they'd be like, great. If you tell your work, I'm having a mental health day and I need a mental health day. Yes, there are places that see it and respect that, but there are a lot of places that will categorize you as lazy, or that you just want to binge watch Netflix all day, right? That you're not working that hard, that you worry about being fired. So even the taboo and stigma and discrimination that surrounds conversations around mental health need to be shifted. But I also think that our approach to self-care needs to be shifted. And that is what I'm going to talk about on March 24th. But, in all seriousness, I think that we tend to focus on individual responsibility. Well, you need to identify when you need a day off. Well, you need to practice mindfulness. Well, you need to figure out your coping strategies. And that is important. We do need to figure that out. I'm not saying we don't. Part of me when I was an ethicist and had patients die every single day, I had to figure out strategies to alleviate my stress and to alleviate my anger and frustration and sadness. But it is also part and parcel of the institution to recognize that and put in specific strategies to help with mental health and moral distress. And so I think, that doesn't answer your question, because I think moral distress just cannot be prevented, unfortunately, with everything that you spoke about. But it is gaining familiarity with what social work can and cannot do, making sure that people understand that there are limited resources and community-based resources, but also having a much longer conversation about what do our institutions and our workplaces owe us. And part of that is what makes an ethical workplace, right? What makes an ethical organization? And part of that is really establishing mental health in their mission and in their aims, that allows for us to say it's not only us as individuals that need to establish that. An earlier question was about support and management and how that connects to moral distress. And I don't think I necessarily answer that, but that connects to this, because I do think that self-care is individual, it's institutional, and it's also interpersonal. Part of our self-care, part of those strategies to mitigate moral distress is being able to vent and talk and build a trustworthy, supportive, strength-based, professional supervisory relationship where you can actually process what happened and process what you went through. And so part of our self-care is interpersonal as well. And so I guess what I leave with is don't feel like it's an individual burden of saying, because it's a cycle, right? You start feeling guilty about not taking a day off, and then you feel guilty because you didn't do your mindfulness. And then mindfulness, like not doing your mindfulness causes stress about doing mindfulness, right? But try and take away some of that individual burden and know that it's not just, it should not be on you as the sole person responsible for your self-care, that it needs to be implemented at higher levels.
That's a fantastic answer. Okay, so we're already 4 minutes over. We could literally talk about this all day, which is why it's so good that there is a part 2. So you can sign up for that on our website. The link is open to register for that. It's also up on our National Social Work Month page, which is socialworkisessential.ca. I don't usually do this on webinars where I talk about CASW's own work, but there's been so many questions in the Q&A about, like, I paraphrase, but what can we do? How do we change this? Like, how do we tell people in charge or policy leaders or our organizations about social work? So I just want to say a few things about that. One tiny thing you can do is on our socialworkisessential.ca website, there's a link to send a form letter to your MP. It's like 3 clicks. You put in your postal code, it automatically detects your member of parliament, and you can send them a letter like explaining your role. It's really, really easy, but it just is going to be a way to help leaders in our country understand the value of what you do, and understand what it is a social worker does and why we are essential, just like doctors and nurses. So that's the first thing. Other people were asking, like, what's the step forwards? I just want to also add that the House of Commons, so the Parliament of Canada, is doing 2 studies right now through 2 different committees on burnout and healthcare workers. And CSW has submitted and will likely appear at both of those committees. So if you want to see what we've said to Parliament on this issue and how we're trying to make it better for all of us, you can go to our website. We post all of our submissions publicly there. So anyway, that's the CSW stuff, just because there were so many questions. But with that, I need to wrap up. I'll do the housekeeping now. The certificate of attendance, it'll be sent to your email in a few hours. I have also had tons of questions from people how to get the recording and if they can share this with their colleagues. Absolutely, please do. It will be available on demand, likely in a few hours, but safest tomorrow through our website, through the same link that you used to log in today. So you can head over to socialworkisessential.ca, and it's on the webinars page. You can just share that link. Sophia, thank you so much. I know you're super busy. We so appreciate you taking the time for this. Literally, I can't even keep up with the flood of thank yous that are coming in the chat right now. Is there anything you wanted to add before we close?
I just want to thank each and every one of you. I mean, thank you, Sally, for organizing this so seamlessly and for inviting me. And just to each and every one of you sitting at your offices or at home on the computer, Zoom exhausted, thank you for joining me to another webinar online, for actually not just signing up and thinking that you'll come eventually and maybe watch the video, to actually being here, and just in general for the work that you do, and know that you are validated and are supported and have shared experiences, and to validate that we are experiencing shared collective trauma right now, and you are not alone in that. And I thank each and every one of you for the work that you do during Social Work Month. So you are all appreciated.
The perfect wrap up. Nothing I can say to top that. Thank you all for being here. Thanks to the audience for your really thoughtful questions and reflections. And we hope to see you all